All righty, let's see if we can get this show on the road. We'll get everyone out of the waiting room and here into the session with us. As you get tuned in, if you don't mind, head over to that chat box. Give me a quick sound and video check. Make sure we're broadcasting loud and clear through the Zoom universe, I guess. So I'm Will. Happy to be here with you today. I am the owner, founder of PT Final Exam. It feels like I've been studying for the NPT for over a decade now. I admit sometimes I have nightmares like, "Ah, shoot, if I've been studying so long, what would happen if I didn't pass the exam, like if I had to retake it?" So, moral of the story here is always keep your license active so you don't have to retake the exam to in order to reactivate the license. So, I guess that's a small moral of the story here today. I'm excited to visit with you today about some of the things we can do for your brain dump. I want to talk about the test day experience. We have a few days here before the January test administration. I know most of you are planning on that, either the January administration, but I know we have some here who are planning on down the road, whether it be in April, July, or beyond. Anyway, we're just happy to have all of you here. So a pleasure. Over in the chat box, I'm going to post the Dropbox link that has the slide notes. If you like to take notes as we go along, please download those. And if you wouldn't mind, inevitably here a few minutes down the road, someone will tune in that they, whatever reason they couldn't get here right when we started. So if you wouldn't mind helping me reshare that link, so if anyone asks for the notes, they're able to download them as they wish. So without further ado, let's go ahead and talk through some of the content. I know we've got lots and lots of you who are here and anxious and want to get through and pass the exam. Let me tell you, it is fun to be on this side of the exam. It's not so much fun to prepare for the exam, but it is one of those things where as you look back, you say to yourself, I'm glad I went through the process. It made me a better clinician, a better critical thinker. There's a lot of really good things about the preparation process as well. So, as always, trying to find the silver lining for the dark cloud. In any case, our plan for today is we're going to talk a little bit about your test day experience, give you some tips as we head into this final weekend and the days before exam. I do want to spend most of our time on material that is likely to be helpful on your brain dump. So we'll talk about what the brain dump is. It's that scratch pad you get on test day and what you can put on it, what you should put on it, what you could put on it, or whether you put anything on it at all, whatever you wish. We'll talk about some of the tips there, some acronyms, mnemonics. I've got those coming down. We'll be playing the hits, so to speak, as I don't know, maybe the kids don't say that anymore. Play the hits. We'll have some fun going through some acronyms, mnemonics. We'll talk about some math and some numbers on the test. That's an example of what I like to put on brain dumps, just because it's obviously easy to forget numbers and ranges, and so we'll talk about that. Plus, I do want to focus on some of your questions. I know a lot of you have questions, last minute questions as we come into these final few days before exam day. So the goal is to go through some of your questions. I'll do my very best to get to as many as I can. If you don't mind, use the Q&A feature in Zoom. It helps to queue them up for me so I can see, so I can kind of group questions and talk about similar topics all together. There's usually a lot of questions about the test day experience, what you can and can't do. We'll definitely talk about that as well. Probably towards the end, we'll talk about your exact test day experience. So anyway, that's the plan for today. Lots of fun. Let's go ahead and start with just a very brief review of what the navigating the test is going to be like. I want to spend most of our time on material, but just a quick reminder of what some of the test experience can be like. And so when it comes to the exam, there is no penalty for guessing. So when all else fails, put down your very best guess. So what does that mean? Your very best guess usually is something that's safe, effective, something that you try to pull yourself out, kind of out of body experience here and say, what would a reasonable therapist do in this case? And sometimes that'll help direct your thoughts to say, all right, well, that feels out of whack. And as soon as you can eliminate at least one item on your answer options, that really improves your chances of getting it right. I have lots and lots. If I had a nickel for every time someone told me I can narrow it down to 50-50, and then I always have a hard time picking the correct answer from 50-50. Well, the reason that is that the writers, it's really easy to write the correct answer. It's really easy to write one or two incorrect answers that are plausible, that look good, but are incorrect. And then usually there's an outlier or something that's a little bit more difficult to write. And so, frankly, that's how the mechanics of creating these questions goes, that you get one really good one and one really good, not correct one. And so your job is to find the things that are the most plausible that line up. Like in our VIP class, we talked a lot about making sure your answer option accounts for all of the information in the question. Because remember, if there's something in the question that doesn't line up, like one of the questions we asked was about someone, I think we asked this one. If I didn't, I should have asked this one. It's about a person who has chest pain, they've got bilateral shoulder pain, it's related to exercise. And then the little line that says, and the symptoms are temporarily relieved by antacids. And you say to yourself, all right, well, you focus on that antacid thing. You say it's got to be GERD, it's gastroesophageal reflux disease. That doesn't account for the exercise-related pain, the bilateral shoulder pain, and that's actually the presentation of myocardial infarctions in women. And so that's one of the things that would be a key safety consideration on exam day, is if you could identify what a myocardial infarction looks like in the older female patient. Anyway, that's an example of making sure your answer accounts for all of the information in the question. The answer options are randomized, so don't worry too much about patterns. Frankly, it's possible you get 2 or 3 A's in a row, but if you get like 15 A's in a row, chances are you need to go double check some of those other ones. Don't change your answer unless you need to. The common wisdom is to never change your answer, and that's not true. You should change your answer if there's evidence to support that you misread it or there's something you missed. Clearly, you should change your answer. Statistics show, I thought this was an interesting study across, I think they had several thousand students, number of of university exams. And they found that more than half the time when a student changed their answer, they changed from wrong to right. So that should give you some hope that if you are changing it because of a good reason, chances are you are changing from wrong to right. Now, it is possible you're going from wrong to wrong or right to wrong. Those are the most frustrating ones. But the truth is, if there's evidence to support change, you should absolutely change. As you go through the exam, there are 3 different strategies you've got to use: the individual, the section, and the exam strategies. So just a quick review on those. I know we talked about these a while ago, but just again, to keep it top of mind, when you're going through a practice question, make sure to read the question. This means that you are seeing the material in the question, identifying keywords, and then double checking one more time that you are answering the correct question with the correct answer. And so that's the read, or read 3 method. After you do that, you should be able to formulate in your mind an answer that, or at least the characteristics of the answer, should be able to formulate in your mind the characteristics of the answer, read through each option, eliminate them as possible as you can, and then identify the most correct answer option. And that's common wisdom for going through multiple choice questions. The target should be about a minute per item. Now, those of you good at math, you're saying to yourself, well, technically we have about 80 seconds per item through the entire test on average. But if you take 80 seconds per item, not all items are equal. Some are a little bit more difficult to read, like the scenario-based items. They take more time. So it's important to target about a minute per item. That also gives you a little extra time at the end of each section so that you can go back and review any items you might have marked. And so target should be about 60. The lengthier or more difficult questions will take a little bit longer. Obviously, the image video questions a lot of times take just a few more moments. In any case, if you can't identify a correct answer, you should mark down your very best guess. Make sure that you have considered everything that you can or that you do know. Make your best guess and only mark the item if you feel like a legitimate another minute could give you the solution. But chances are, if it's something you have no idea about, like in the VIP class yesterday, we had this question: what if there's a question that you just have no idea about? Well, in that case, cut it loose. I mean, the likelihood of you getting it correct is very low, and it's likely to take time away from questions you could get right. And so therefore, you should spend only the bare minimum time on the most difficult questions. You should spend more of your time on things you're likely to get correct. And again, it's just a question of kind of that self-analysis. Is like, am I just totally guessing here? Well, if it is a total guess, don't bother marking it. Just put down your best guess. Make sure to select an answer, and then move on. So don't avoid, or do avoid, spending extra time on questions you're unlikely to get right, because it takes time away from the ones you could get right. Each section should take a maximum of 1 hour. Now, you do get the 5-hour time bank, so you can use it as you wish, but I very much recommend staying within that 1 hour per section. Again, these are things you know. I'm just giving you a quick reminder here to say 1 hour per section is a really good target. If you go over in one section, though, it means you better kick it in gear for the next sections, because you're taking time away that you could be spending on the other ones. So rather than try to track 1 minute per item, I do suggest about 30 minutes, so half hour per half section. Just easy math here. Half hour per half section. That's how you know you're on pace. Most of you probably will finish a little bit quicker than that. I have had people who've gone right up to the wire. I've had people who have had the timer end without selecting answers on every item. The good news is every item that you have selected an answer will be graded, whether or not you submitted that section, that final section. So that should be good news that if you're down to like 30 seconds, just start clicking. Like just click every answer you can because you have a greater chance of getting that correct than if you leave it totally blank. Navigate through the easiest questions first. We talked about that. And then make sure to not spend more than a few minutes on your marked items. This means marking very judiciously. I had a student a few years ago who she marked every item on the test. And this was when it was 250. She marked every item on the test. And when you do that, there's a psychological trigger you must return. And so she did. She went back and returned to every single item. And she said it was exhausting. She failed the test because she was so exhausted by the fifth section. She just couldn't remain focused with that many questions in that. It was like she doubled the amount of questions in the same amount of time. So mark judiciously is what I say. And then finally, the full exam. You have the 5-hour time bank to use as you wish. You get a scheduled test or scheduled break after section 2. So what does that mean? That means that you check out. It's a 15-minute mini timer. You check out of your exam. You have to, obviously you have to have all of the security measures done and redone as you exit and return back to your exam. They have to take your picture, your palm print, all of that to make sure that you are you. So just remember, 15 minutes gets whittled down pretty quickly by the time you go through all of the security procedure. So therefore, just make sure that you're not planning a lot of lengthy things during your 15-minute break. When I took the test, I went out in the stairwell, walked up and down the stairs a few times just to get my blood flowing. I was kind of, I don't know, not too stiff and sore for being at the desk, but it was something that was good to get up and move, be very kinesthetic. Plan your snack. I've talked about this a bunch of times in our VIP class, but just make sure that you are planning something that's not high sugar or high caffeine, just because you can have a sugar crash or a caffeine crash or have the diuretic effect of caffeine kick in. So just plan something that works well for you, whatever that is. You get to keep that in your locker. You don't have to bring a lock. They have everything there provided. So you just walk in, you check in, they'll give you a locker, and then you go to that locker and you dump off all your stuff, all the things you don't need for the exam, like your phone and your keys and your lunch. Do plan that extra time for checking in and checking out, though, because it takes some time. And then ideally, you'll move quickly and efficiently through the questions, leaving just a few minutes for a quick double check. So again, you don't have to like mark every item and go back and look at every item, but it is nice to have marked a few of the most difficult ones so that, or not the most, the ones you're never going to get right, don't bother marking it. But the ones that you had to think about for a minute, mark a couple of those and go back and just double check. I guess it just depends on how much time you have. Some of you are very fast test takers, and that's great because you'll finish in time, but it's tricky because you have to avoid misreading questions or skipping over things going too quickly. So just be cautious. You don't have to reinvent your test pace. Like I had a student a few years ago who was a very fast test taker, and he said that he got into the test and he tried to use up all of his time, and so he stretched out all of his exam time. And he was so worn out and fatigued by the end, he did fail the test because he was trying to reinvent his test pace on exam day. So don't reinvent it. Just go with what feels comfortable to you, what you've practiced. If you are a very slow test taker, then you got to kick it in gear. You have to make sure to finish in that 5-hour time frame. There's no way around it. You have to stay on pace so you have adequate time for each item. So there you go. There's I guess you could say the question strategies, the section strategies, and the entire exam strategy. Let's see, I got a couple of questions here. Question comes across, will there be a recording of this session? Yes, indeed. So we'll record it and post it to our crash course and our VIP course. I'll probably even post it to our YouTube channel, at least a selection of it, make sure that's available to you. All right, so, and then there's a content question. I'm gonna hold on that for a minute. We'll go through some content here as we go through. So let's talk about the brain dump. The brain dump is, simply put, it's a scratch pad. It's a scratch paper. During COVID, it was actual physical paper with a pen that was disposable. Most of the time, though, now I'm not aware of any test centers that have continued pen and paper. I think most of them use a dry erase laminated piece of paper. It's extremely simple. It's really nothing fancy. Once you get it, you're like, oh, this is a laminated piece of paper. And you get a dry erase marker. If at any point during the test you wish for another pad, another scratch paper, or another marker, or your marker's not working, you just have to raise your hand and get the proctor's attention, and they will bring it to you. So they provide everything. You don't have to bring anything. You don't have to bring a marker, no paper. Everything is there for you. What you can do, though, is prepare in your mind what you will dump off onto that paper so that you don't forget it. Like one of the favorite ones that I like to do is the cranial nerves. That's one that I always get mixed up if I don't have it written down or right in front of me. And so that would be an example of what you could put there. There's a couple of acronyms we'll talk through here in a minute. Mnemonic devices that are helpful, again, that you can quickly write on a scratch pad so that you don't have to worry about it on test day. And it's interesting the psychological trigger it is that if you know that it's on the paper and that you won't forget it, even though you probably didn't need it because you prepared for it, just having it there can help you answer questions more quickly and efficiently. So yeah, the brain dump is kind of a handy little tool. Like I wouldn't spend a ton of time on it, but it is nice to have that and to jot down a few of the items you don't want to forget. So most test centers will tell you don't start writing until you see question one. But there is a tutorial section of the exam. This is where they teach you how to click a mouse and advance through the items. I have had some students report that the Prometric centers they're not too worried if you're sitting in your seat and you're doing the tutorial, which you get 15 minutes to do the tutorial about how to click a mouse and advance through the questions. I believe some of them will permit you. Just double check with your local test center that day. Say, hey, when can I start writing on this? And I think most of the time they let you go as soon as you're sitting in your seat. But I have had some, maybe it was just one stickler proctor that was like, hey, you can't start writing till the actual clock starts. But you can tell me what your experience is. Just double check with your test center staff that day. All right, so just a couple freebies here. The NPT podcast, I know we're only a few days from exam day, but I go through a practice question in each of those. So it's really pretty fun to go through practice questions. I hope you'll check that out. The VIP course, we've got lots of you who are here today that are part of the VIP course. And anyway, it's a fun one that we go through tons of questions. I mean, those are my VIPs here. What do? We do practice questions. We practice. We have one-on-one calls. It really is a great resource. So you can check that out as a part of PT final exam. All right, so the best brain dumps are brief and usually some type of abbreviation or acronym. Super, super handy to be able to go through it quickly. So for instance, like you could just write 666 and perhaps there's some other connotations to the 666, but the 666 rule has saved my bacon so many times. 6 weeks of maximum protection after a major musculoskeletal repair. So what does that mean? It means that with a major musculoskeletal repair, like an Achilles tendon repair, an ACL tear, most of the time, the first 6 weeks, you're all in anti-inflammatory phase. You're trying to reduce the tissue reactivity. You're trying to reduce inflammation. You're trying to maintain some baseline strength, so some passive range of motion and maybe some isometric activation, but really taking it easy on excessive range of motion or weight bearing. So most of the time, that first 6 weeks is the maximum protection phase. The second 6 weeks is the moderate protection phase. So that's between weeks 7 and 12. Moderate protection, this is when PTs really shine. You know, we do a lot of great stuff during that second 6 weeks. And that's when we start we go from passive range of motion to active range of motion, working at the end of that towards what we would consider kind of a restoration of function, or we'll call it resisted range of motion. So if we add an extra R, resisted range of motion. If the person is trying to target high velocity, high load activity, 6 months. And like I said, as a first year clinician, this was my go-to. Like I saw that pattern in the rehab protocols, and I knew that if I could apply that effectively to each patient as necessary, obviously there's some nuance here. But if there was a patient who walked in and was like, hey, I just had whatever done, what do I do next? I knew that if we're in the first 6 weeks, we're doing probably some ice and anti-inflammatory modalities. We're probably doing some basic passive range of motion in mid-range, probably doing some just real baseline submaximal isometrics. And so with that in mind, I could lock in a good treatment procedure from the get-go and then obviously change it or augment it as necessary down the road. So 666 would be a good item to put on the brain dump. Another one that's a super fast one is salute. The upward rotators of the scapula are the serratus anterior, lower, and upper trapezius. So just like you salute, bring your hand up, going in upward rotation. That means that those three are working in unison to upwardly rotate the scapula. If you love ramen, that's the levator, rhomboids, and pec minor. So I know that's a little bit of a stretch, right? If you levator, rhomboids, and so if you have to spell it funny here, love ramen tells you that the levator, rhomboids, and pec minor are downward rotators. So again, a mnemonic device to help you remember upward versus downward, because I can almost guarantee like 85% chance that you'll get an exam question that asks you about something related to weak upward rotators or poor upward rotators, and you have to know which ones they are, know how to counteract that, and then they ask you what the resting position of the shoulder would be. Well, if you've lost the upward rotators, you're stuck in downward rotation. So that's an example of how you could problem solve, just knowing which muscle groups are being activated, problem solve what to do next. So this is just putting it in table form. The upward rotators are salute. The downward rotators are love ramen. A protraction, obviously, the serratus anterior rhomboids. Depression, the latissimus dorsi. Let's see, what do I have? My goodness, what am I doing? Not the levator. Sorry, elevation is the levator scapula, and then depression is latissimus dorsi. I was just looking at the wrong column here. But in any case, the levator scap and the latissimus dorsi for elevation and depression. Let's see, a question comes across. A second time test taker here, and my test froze the first time. Any advice for refocusing if this happens again as the PTA exam had problems? I mean, my only advice if you have like computer issues on exam day is just get your hand raised right away, get the proctor over, just make sure it's documented clearly, because chances are if there's a true disruption, they'll let you retake like right away. But if you say nothing and it just falls apart, then they don't have any documentation of what went wrong. So the anxiety and stress, that is tough to combat on test day. And I'll talk a little bit more about this at the end, but some of the best ways to combat anxiety is to control what you can. Starting with like your posture and your breathing, you can control that, and that tends to lead to a better performance. And so control what you can in order to combat the anxiety. All right, other items here. So just, I don't know, a couple little things just to keep in mind. One of the other little acronyms is VOA for vertebral artery testing. For vertebral artery testing, you're testing the opposite artery, meaning that if you turn left, you're testing the right artery. If you turn right, you're testing the left artery. That's the vertebral artery test. I saw a question, it was a really nasty question about the alar ligament. The alar ligament locks C1 and C2 together for side bending. And so side bending is locked in, meaning that if you start C1, you should see an immediate movement of C2 with left side bending. And so that's where the all or nothing comes in for the alar ligament. It's either all or nothing. So the alar ligaments, that's what these guys are. So those alar ligaments, they lock C1 and C2 together for side bending. So you should have it exactly locked in. The sharp pressure test, this is another example of just, you've got to know more than just the name of the test. You have to understand what it's precisely doing. So the sharp pressure test is where you push back on the forehead, and if it relocates or clunks back with a reduction in symptoms, chances, and that is a positive sharp pressure test. So a funny way to think of this is like if someone's trying to kiss you with pursed lips, so they have pursed lips, you push them back, and that's how you do the sharp pressure test. So in any case, it's a relocation maneuver for the transverse ligament. Speaking of the transverse ligament, probably another 85% chance you get a question related to transverse ligament, because it's a key safety issue. If the transverse ligament that holds C1 and C2 together is, so not the alar ligament now, the transverse ligament that holds the odontoid process of C2 on C1. So what are some of the causes? There are a couple of key ones you've got to know. What are some causes of transverse ligamentous laxity? So high on the list would be injury, some type of like a whiplash associated disorder or a motor vehicle accident. But what other conditions? So high on that list would be Down syndrome. I know that there will be questions about like if a child has Down syndrome, what would you do, or what would the recommendations be for activity for a child who has Down syndrome? So you avoid somersaulting. You try to keep the neck from getting any axial loading. So you would avoid somersaulting, so rolling over, and you'd also avoid trampolining or contact sports because of the shock that it can create on that transverse ligament. Ehlers-Danlos, rheumatoid. I feel like this is kind of the dark horse here. Rheumatoid arthritis is a significant cause of transverse ligamentous laxity. So again, something to watch for. If, let's say you have an older adult patient with rheumatoid arthritis, and now they've got cervical symptoms, that should be one of the things you think about. Like, all right, maybe transverse ligament. Marfan syndrome, Ehlers-Danlos, all those lead to transverse ligamentous laxity. So those are key things to keep in mind. I can almost guarantee a question on exam day related to insufficiency, active and passive insufficiency. So active insufficiency, I want everyone to make a nice fist for me. And I want you to make that fist, though, with flexion and finger flexion. And you'll find that that's very difficult to get a good power fist. And that's called active insufficiency. The long finger flexors cannot sufficiently contract in order to create a good, strong fist. So like the question on test day is going to be, say something like this: what is the best position of the wrist for what is it? Basically creating a powerful grasp. And you'll see that it's about 30 degrees of wrist extension in order to get the best contraction of the long finger flexors. Let's see, Morgan says, took a PEAT today that had at least 4 to 5 active or passive insufficiency questions. Yes, so I guarantee this will show up because it's such a key problem-solving task that we do as PTs to distinguish between agonist issues versus antagonist issues. And you have to problem solve about, all right, let's say you can't move. Like one I saw just the other day was a patient's having difficulty moving into internal rotation. What's the problem? Well, it's probably the external rotators that are tight. So internal rotation requires a sufficient laxity of the external rotators to go into that position. And so that's an example of understanding the agonist and the antagonist movement of the muscles. Passive insufficiency, one of our favorite examples ever, and this is Will to a T here, is that as you're doing hamstring testing, you'll find that it's difficult to go into hip flexion with the knee extended. But if you flex the knee, then you can get a lot, that's very long foot. You can get a lot more hip flexion once you flex that knee. And that's an example of passive insufficiency. So those are things that definitely show up on exam day. And so Bibbin points out the sign, like the sign of the buttock. That is exactly right. Sign of the buttock is you try to go through the range of motion. I'm trying to remember all the details of sign of the buttock. Usually sign of the buttock, that's where you have tightness, but it's usually due to some type of external cause, like a sacral fracture. My goodness, yeah. I'll have to pull up a picture of that here in a moment. But yeah, that's an example of passive insufficiency. That's exactly right. All right. Oh, and this is the question that this sometimes shows up on the test. Probably a 40% chance this will be on the test. Is can passive insufficiency ever be helpful? And the answer is yes, of course it can. In several cases, usually related to spinal cord injury. This means that like you want to keep the hamstrings at about 100 degrees of range of motion. That's so that as the person is in long sitting, they can achieve long sitting, have a good base of support. About 100 degrees takes them past 90 so that their center of mass is on top of the base of support. And by so doing, they can tie their shoes and dress themselves more easily. So that's an example of how passive insufficiency is a little bit helpful. The quadratus lumborum as well. In spinal cord injury, you want the spine to stay upright. So quadratus lumborum. And then finally, the tenodesis grasp. You don't want to overstretch the finger flexors because you need that good tenodesis grasp with like a C6 injury as you extend the wrist. That's exactly right. All right. So the next one here I wanted to talk about, and like I said, I do see some of the questions that are queued up. I'll try to group those here as we talk through some of these other things. All right. There was a great question that came up. This was over in, I want to say this was in the crash course chat, asking about pulse grading. And I'm not even gonna list anything else other than 2+ is normal. And I know, believe me, I know all the library of books I've got that O'Sullivan says one thing, Hilligas says another thing, and it's like, which one's which? All I'm going to say is on Pete questions that I've seen, 2+ is considered the normal. So for pulse grading, go with 2+, and we'll just call it a day there. I know it's pain because there is some disparity in literature, and frankly, that's unlikely to directly show up on the test. They'll probably ask about the the extremes of, if the pulse is too low, it's like a 1+, or if the pulse is too high, it's a 3+ or 4+. So that's what to watch for on test day. All right, cranial nerves. Talking a little bit about neuro here. Some of the fun cranial nerve mnemonic devices would be like, oh, once one takes the anatomy final, very fine or very good vacations are heavenly. The one I learned in PT school was on old Olympus towering top, a finely vested German viewed a hawk. Whatever it is, however you remember it. The one that can be really helpful, though, is the sensory or motor mnemonic. Some say Merry Money, but my brother says Bad Blood Merry Money. There's some less G-rated versions of that, but S means sensory, so it starts with S. Sensory, sensory, motor, motor, both, motor, both, sensory, and as it goes on. So I have those listed here that, like a lot of times I'll ask students what their favorite cranial nerve is. And usually first person that answers that question says the olfactory, because it's very simple. Olfactory nerve, you just test the sense of smell. It is a true pure sensory branch or pure sensory cranial nerve. Now, some of the problem solving you'll see about the cranial nerves will sometimes be related to the origins. This is where another little mnemonic comes in. CEMI, PONS, So the first two, CE, is for cranial nerves 1 and 2. MI, there's 2 letters in that, so MI, you get 3 and 4. PONS has 4 letters, you get 5, 6, 7, 8. And MEDU has the last 4 letters, 9, 10, 11, 12. So this is helpful if you have a medullary stroke. Chances are it'll affect cranial nerves 9, 10, 11, and 12. So 9, 10, 11, 12, that's a key part of a medullary stroke. Pontine level lesion, probably have a lot of facial issues, so 5, 6, 7, 8. This is not an end-all be-all, but it's a really helpful starting point for a lot of these questions. So if you can remember the mnemonic see my pons medu, that'll again help lock in where the cranial nerves originate. Excellent. Let's see. So while we're on the topic here, active and passive insufficiency is a concept I've always struggled with. Can you give more specific examples of which muscle group is actively or passively insufficient with a specific movement? Sure. So the simplest one for active insufficiency is, like I said, make a nice tight fist, but active insufficiency means that a muscle cannot contract enough to go through full range of motion of both joints. So it's a 2-joint muscle that crosses it. So for instance, long finger flexors, they cross the hand, right? So if you flex the wrist, that's finger flexors are kind of helping with that. And then you flex the fingers, they just can't, they can't give anymore. They've already given all they can, and they're kind of stuck. So they cannot continue flexing because the muscle is insufficient to do full range of motion. So the key with identifying the difference between active and passive insufficiency is usually if the target muscle is contracting or if the target muscle is stretching. So it's all about target muscle active range of motion or target muscle passive range of motion. Another good active insufficiency example is elbow flexion with shoulder flexion. You'll find it's very difficult because the biceps are a strong shoulder flexor as well. So elbow flexion and shoulder flexion is another example of active insufficiency. The biceps just cannot, they can't hack it. They just can't go through full range of motion of both the elbow and the shoulder. They just kind of give up halfway through and they're like, that's what we got. So that's an example of active insufficiency. The passive ones are all about stretching, and the classic one is the hamstrings. Chrislin says, do you name passive insufficiency by the agonist or the antagonist? Well, it's all about your terminology. So if you consider the hamstring, the target motion is hip flexion. So if you say, I want to move into hip flexion, but I can't because of passive insufficiency of the hip extensors, so the hamstrings. So in that frame of mind, you'd say this is the antagonist to the movement. So that's the antagonist to the movement. So passive insufficiency of the hip extensors as you attempt to move into hip flexion. Megan asks, is active insufficiency happening when a patient cannot get full knee extension due to tightness of the gastroc soleus, or the gastroc complex, since it crosses and attaches to the femur? So kind of, Megan, you just have to take one more step there. So as you consider the leg, let's say you want to go into full dorsiflexion dorsiflexion with knee extension. And I want you to try that on yourselves right now. You'll feel that it stretches the backside of your leg. And so if you cannot achieve full dorsiflexion with full knee extension, that would be a passive insufficiency of gastroc, because it does indeed cross the knee. Question comes across in the hip flexion or the hip extensor, or I should say the hamstring example. The question is it related to the gluteus maximus? It is not, because the gluteus maximus does not cross the knee joint. It is the hamstrings that are at fault here, because they cross both the hip and the knee joint. That's a part of active and passive insufficiency, is it must be a two-joint muscle. Excellent. Great questions, by the way. Really good questions. Is it correct to say that active insufficiency is shortened, whereas passive insufficiency is fully lengthened? Kind of. Remember, active insufficiency is an active movement, whereas passive range of motion is a stretching movement on the target muscle. So yes, it is sufficient to, yeah, you're right that active insufficiency is shortened, but it's an activated muscle. Excellent. All right, let's talk now. Spondylolisthesis, this is one where just keep it straight in your mind. And you might list spondy on your brain dump. Just put the term spondy. And then try to remember the 4 different categories related to spondy. You've got spondylosis. So losis is basically just stenosis. I don't know, it rhymes maybe? I don't know if that's enough of a rhyme there. Spinal stenosis, spondylosis. And this is where you have a narrowing of the intervertebral foramina leading to the shopping cart sign. The shopping cart sign means that when you go shopping, it feels better to be in a flexed position. So they prefer flexion. It feels better. Extension, they don't like. Ankylosing spondylitis. So spondylitis, this is an acute inflammatory response, or chronic, really acute turning to chronic. Inflammatory response, autoimmune disorder, usually affecting middle-aged males, where you have this pretty profound stiffness in the back that lasts for a long time each day, with loss of range of motion in the spine, sacral pain, ankylosing spondylitis. It's bamboo spine, so it's another spondy. Spondylolysis, lysis is the suffix that means breakage. So spondylolysis means a Scotty dog fracture. That's you can get some anterior slippage if you've broken one side. It does start to slide a little bit. And then finally, spondylolisthesis is a true anterior translation from a bilateral fracture of that pars intraarticularis. So it's the spondylolisthesis, the very long named one is the one where you have it slipping forward. So if you can just keep the spondies in mind, you can just write the term spondy times 4 or something. Just remember there's 4 different suffixes to spondy that can help you identify what's going on test day. Spinal mobilizations. I'm just going to give you the super brief rundown here. There's a lot that could be said. I mean, there's chapters written about this stuff. So the thing to remember, the cervical spine, mid-typical cervical spine between C2 and C7, side bending and rotation occur in the same direction. Side bending and rotation occur in the same direction. So that means if you side bend right, I can't spell here. So if you go side bending and rotation occur in the same direction. So if you do right side bending, it leads to right rotation. In the thoracic spine, it follows the same rule. So same direction, side bending, rotation occur in the same direction. The lumbar spine is goofy because it's opposite. That means if you do right rotation, it will result in a left side bending at the facet joints. Now remember, it's not like you're falling over, but it's, if you look at the facets and the vertebral bodies, they're doing this wonky rotation side bending at the same time. It's all based on the shape, by the way. This is just shape related. You know, as the anatomists looked at the shape and they saw as it moved in space, they said, oh, you know, there's a coupled pattern here. It's either the same direction or the opposite direction. So that is the ultra simple. The likeliest one to show up on the test is probably this cervical one. I have seen a couple about the lumbar, and I guess about thoracic too, but thoracic and cervical, they follow the same rule. Lumbar is goofy because it's the opposite. Side bending and rotation occur in opposite. If you look at more of the text on this slide, you'll see there's some nuance there about if you do side flexion first, what happens, or if you're in the atlanto-occipital joint, what happens there. I wouldn't even worry about that. I would just put that from my mind. Not likely to be tested because it's weird and not clearly defined in the textbooks. But the ones that are clearly defined are these basic side bending and rotation rules. So if you can remember, cervical, thoracic, same, lumbar, opposite, side bending and rotation, you'll be golden on test day. That will help you immensely on the exam. Excellent. So other musculoskeletal things I just want to mention here before we dive into some neuro. Shoulder mobilization. I guess we've kind of done some neuro already. A little mix and match here on stuff. Shoulder mobilization, it does indeed follow the roll and glide rules, the convex rule. It is indeed convex, which means that roll and glide occur in the opposite direction. So convex is opposite. And so as you want to, let's say you want to do internal rotation. So internal rotation, it requires a posterior glide. External rotation requires an anterior glide. Abduction is an inferior glide, and then shoulder flexion usually requires posterior and inferior, especially in the end ranges. In any case, it's just applying the convex rule. There is one major exception though, and I haven't seen very many questions about it, but I just wanted you to keep it in mind that if the test question says something about adhesive capsulitis, then just do a posterior glide. Like that's going to help everything. So that's what's in the textbooks, that if there's a capsular restriction, so anterior, really adhesive capsulitis, you will do a posterior glide. Posterior glide. Everything else, just follow the rule. Just follow anterior, just everything. Follow the rule. Like an example, another example I saw was a patient was trying to scratch their back up as high as they could. What mobilizations would be required? Well, the key they were going for was its internal rotation to reach up and scratch your back, right? So it's internal rotation, posterior glide. But they also were abducting the arm in order to reach higher up on their back. So required an inferior glide. So posterior and inferior was the best for getting that back scratch position. Excellent. All right. A couple more little mnemonic devices here that you can put on your test. Randy Travis drinks cold beer. That's the roots, trunks, divisions, chords, branches. I saw a question recently. We did this in the VIP class. If a person had a heavy load on their shoulders, what damage would likely occur? Well, it's probably going to be pulling down on C5 and C6, the upper trunk of the brachial plexus, because that load on your shoulders, like a backpack, is going to pull down on C5 and C6. So that would be an example of something you can see on test day. These other ones, like these fun little acronyms, the radial nerve is a beast. So you've got your abductor pollicis longus, your brachioradialis, the extensors, the anconeus, the supinator, and the triceps all are innervated by the radial nerve. And let's see, did I include? I didn't include my my key here. Do you guys want me to go through the mnemonics? A beast, half loaf, pumpernickel, and mafia. This is how I remember the brachial or the terminal branches of the brachial plexus. So, a couple of yes, please. Yeah, okay. Let's do it real quick. So, as an example, the radial nerve, don't do that either. The radial nerve is a beast, which means that it's the abductor pollicis longus, brachioradialis, the extensors, and conius, the supinator, and the triceps. I should also mention that there's a branch of radial. It's called the PIN, the posterior interosseous. Interosseous. We had a great question about this in our VIP class yesterday, but the key with posterior interosseous is you have extensor weakness, coupled with really, there's no distal sensory changes. And then usually the pain or dysfunction is near what's called the arcade of Frosch. Which is, try to spell, it's a funny spelling. Arcade of Frosch, which is basically near bifurcation of supinator. So that's the radial nerve. Is that helpful? Tell me, am I talking to myself here just as I go through this, or is this what you want to talk about? Some of these fun little mnemonic devices. All right, so then the median nerve. This guy is the half loaf of pumpernickel. So this is where you get first and second lumbricals, the opponens pollicis, abductor pollicis brevis, the flexors on the radial side. So like flexor carpi radialis longus, flexor carpi radialis brevis, flexor digitorum longus, or sorry, flexor digitorum superficialis and profundus on the radial side. Everything on the radial thumb side. And then the half loaf of pronators. We got the pronators. So pronator, teres, and quadratus. This has a fun branch too. This is called the anterior interosseous. Do this. Put all these guys back. Anterior interosseous nerve, and this hits the flexor pollicis longus plus flexor digitorum profundus. And so that's what does the tip-to-tip pinch. All right, so that's the median nerve. Last one is the ulnar nerve. And this is what is the mafia. So this is, you have to go with me here on this one. You have the medial two lumbricals. So everyone put your hand in anatomic position. Medial two lumbricals means it's on the fourth and fifth digits. Medial two lumbricals, the adductor pollicis, the flexors on the ulnar side, the interossei, and the abductor digiti minimi, or abductor digiti quinti. So those are the radial nerve is a beast, median nerve, half loaf pumpernickel, ulnar nerve is the mafia. The one thing to remember about the ulnar nerve is what's called Guillon's canal, which is formed by, it has an aponeurosis, but also it goes by the pisiform and hamate bones. So if you have injury near the hamate bone, there's a chance you'll get disruption downstream of Guillon's canal, which will lead to the ulnar nerve intrinsic muscle loss. So abduction of the fingers, adduction of the thumb, those would be things that would be lost with Guillon's canal issues. So loss of ulnar nerve intrinsics. And oh my goodness, there's going to be, yeah, there's going to be a ton of, maybe not a ton, but a bunch of questions that ask you about if you have a nerve injury here, what happens downstream. So if you have an elbow level injury, the forearm will be affected. But if you have a wrist level injury, the long forearm muscles will not be affected. So that's an example of some problem solving you'll have to do on test day. Excellent. I did list the lower extremity ones that aren't nearly as cool. So femoral, I'm not as fond of these little mnemonics, but F quips for the femoral, which gets quads, iliacus, pectineus, sartorius, saphenous. Deep peroneal is DPTEEE, which is the deep peroneal, gets the tibialis anterior plus a lot of extensors. Superficial peroneal, SPLB, gets the longus and brevis of peroneus. And then finally, the tibial is the gas plant. You get the gastroc, soleus, plantaris, popliteus, tibialis posterior, all that from the tibial nerve, and then the flexor digitorum longus and flexor hallucis longus. So I don't know; those ones aren't nearly as cool, but those are some examples of what you could put on your brain dump as some little mnemonic devices. A little follow-up question: does it matter what stage of adhesive capsulitis to your posterior glide in? It does, because if the joint is extremely reactive, you won't be really doing much gliding because it hurts so bad. So you'd probably be in the, not during the acute freezing phase, but probably in the moderate to end phase. That's when you'll really be doing a lot with PT with someone with adhesive capsulitis. Question comes across: is manual muscle testing for the pelvic muscles important? I mean, it is important, but for exam day, I wouldn't spend a lot of time there. There's only what? Oh, I have it listed here. How many questions on the genitourinary system? So we've got what? Somewhere between 2 and 5 questions. It's not likely they'll test you on the manual muscle testing of the pelvic floor. Rather, the test will be about interventions of the pelvic floor. So I wouldn't spend too much time on that. All right, blasting through a few other things. We've got a bunch of claw hands. The median claw, it's all about what you're trying to do. If you're trying to make a fist and the first 3 don't move, well, that tells you the median nerve is not working. The thumb side is not flexing. So that's an example of a median claw. Attempt to make a fist, first 3 digits don't move. If you're trying to hold your hand at rest and the 4th and 5th are a little bit flexed with full range of motion, full passive range of motion, that tells you you have loss of the 3rd and 4th lumbricals related to the ulnar nerve. So it's hand at rest, you get that claw hand. Debutans contracture is a true loss of passive range of motion. It's where you have a true aponeurosis issue, contraction of the fascia layers of the palm. So palmar fascia loss, that's the debutans contracture. Erb's palsy, I just listed it here. It's not really a claw hand. It's loss of the upper brachial plexus. So you get stuck in this elbow extended position, the waiter strip deformity. And then finally, Klumpke's palsy. This is kind of a claw hand, loss of intrinsics with loss of C8 and T1. So that's a lower brachial plexus injury, loss of C8 and T1. Oh, and I forgot to ask you guys, I need to ask you this question, because this, oh my goodness, this is going to come up on at least 2 questions. I can almost guarantee 95% chance there'll be 2 questions about this. The question will be about the nerve roots and where it exits the spine. So we're going to draw 2 vertebral segments. These are our vertebral segments. My question to you is, which vertebral segments segments surround C5? Which vertebral segments surround C5? That's my question to you. Which vertebral segments surround C5? So we know that the cervical nerve root exits above its named vertebra. So we know that C5 is below, or the C5 nerve root exits above C5. So this is indeed C4 and C5. That's where C5 exits. Now we get to the tricky one. I guess it's not that tricky, but tell me what, and I guess you can just count down here. What vertebral segments surround C8? Remember, there are only 7 cervical vertebrae. So what vertebral segments surround C8? Well, we know that C7 is here, and so T1 is right below it. So it's between C7 and T1 is where the 8th cervical nerve root comes out. The next thing I want you to do, I want you to point to the dermatome area for C8. And the way I want you all to hold up your hands, C6 is on the thumb, C7 on the middle finger, and C8 on the little finger. And I want you to do that like 10 times right now. C6 on the thumb, C7 middle finger, C8 little finger. That is something, again, an example. You won't put that on your brain dump, but you can take it with you in test day and just have that reminder: C6 on the thumb, C7 middle finger, and C8 on the little finger. And then that helps you identify what the nerve roots are doing with as far as the dermatomes go. Excellent. All right. So then let's talk now about some of the math on exam day. So some of the numbers you'll see on exam day. As an example, would be like Karvonen's method. Karvonen's method is simply looking at the heart rate reserve. And what in the world does that mean? Heart rate reserve is simply the heart rate at rest as it compares to the heart rate maximum. And I want you to think about that for a sec. That's like the maximum you could possibly do heart rate, and the minimum resting heart rate. That's the top and that's the bottom. You can't. You're obviously not. Hopefully not going to 0 heart rate. Then you've got big problems if your heart rate goes to 0. So the resting heart rate is the baseline. So from the bottom to the top, that's called the heart rate reserve. So you predict the heart rate reserve from the age predicted heart rate maximum. You can measure it too, but most of the time we just predict it with age predicted heart rate maximum minus the resting heart rate gives you this heart rate reserve. Most of the time, our exercise is targeted to be about 40 to 85% of your heart rate reserve. And so then you just have to add it back to the heart rate at rest. So your target heart rate is your resting. That's your baseline. I mean, you can't go lower than whatever it is, 60 or 50 or 80, whatever your heart rate at rest is, plus your target heart rate reserve gives you your heart rate, your target heart rate. So that's an example of math that could be on the test. The one, I don't know if this helps, but you can tell me this is how Will does it. If you don't like this, then kind of block it from your mind. But let's say, just for, I don't know, for kicks and giggles, let's say that our patient is, let's just say our patient is 60 years old. So with that information, we know that our age predicted heart rate maximum, age predicted heart rate max, is going to be 220 minus our age of 60, which takes us to 160 beats per minute. And so then that is our heart rate. What am I trying to say? No, this is our heart rate maximum, heart rate max. You have to know the heart rate at rest. Heart rate at rest is typically given to you. We're just going to go ahead and say that our heart rate at rest is, try to make it not too difficult. Let's just say it's 100. We'll just say it's 100. So we take our age predicted max minus our rest to get our reserve. So we get 160. That's the top. That's the max. Minus 100. That's the min. So that's observed, the heart rate at rest. Gives us a heart rate reserve of 60, right? So now we're down to 60. So now how do we calculate a percentage of 60? This is where a little bit of Will math jumps in. You can tell me if this is helpful or not. I have a hard time calculating funny percentages, like 85%. That sounds tricky. I can calculate 10% pretty easily. I know that 10% of 60 is 10% of 60 is 6 beats per minute, right? I mean, that's just basic 10%, just move a decimal point over 6. And so then I can start doing a little calculating. I say to myself, well, if my, let's say I want to add back 85%. So we're going to take our heart rate at rest, which is 100, plus our target heart rate reserve, let's say 85% of heart rate reserve. Well, I have to figure out what that is. What's 85%? Well, what's 85% of 60? Well, 60 minus 6, so that's 10%. So if we take off 10%, we know that 90% is 54, right? And if we subtract another 6, then that takes us down to 80%, which is 48. So you can see where I'm going with this. Well, if I just split the difference, or if I just subtracted 3, then that would give me my middle ground here, which would be 51. So 51 is 85%. So that gives me my heart rate at rest, gives me my target heart rate reserve for the grand total of 151. So I guess the moral of the story is it's pretty easy to calculate 10%, and I can do math based on 10%. It's pretty easy. So another example of math that'll show up on the test would be something like the ankle brachial index. So the ankle brachial index, this is looking at your systolic blood pressure of the ankle to the systolic blood pressure of your arm. And the way that it's named is how you calculate it. The ankle divided by the brachial gives you the ankle brachial index. So for instance, let's say that our ankle blood pressure would be observed. Let's say our ankle was 80. So the systolic was 80 millimeters of mercury. And our brachial was listed or measured to be 100. Or let's do 120. 120 millimeters of mercury. So then at this point, we take our 80 divided by 120. And you see that, I mean, you could do this even more simply, but you could do the long division. You could also do, I guess what I want to say, the easier way to do it is to do 80 divided by 120. And then you can start to take the factors out of it. So you have 8 divided by 12, which you can see where I'm going with this, is you can take that down to divide by 4. So you get 2 over 3. So divide top and bottom by 4. So divide by 4, divide by 4 gives us 2/3, which is 0.66. So that would be an example of the ankle brachial index. Question comes across, do we have basic calculators on the exam? Negative. No calculators on the exam. No phones, no calculators, no basic calculator function. It's all on your scratch pad. This is what that brain dump is for, is doing a little bit of basic calculation. So I don't know if that's good news or bad news. Probably more bad news than anything. But the good news is the math will be very simple and straightforward. Like, can you calculate 10%? Can you factor out a ratio to see what exactly it is? Excellent. Question comes across, is 0.8 where compression is contraindicated on the ABI? I believe so. I believe that is the case, that someone with peripheral arterial disease, it's not good to add compression. So if they're in the moderate disease category, then you're not. If you start squeezing on that leg, it's only going to make the peripheral arterial disease worse. Excellent. All right, other math on the test. I'm going to ask you this question. You already saw the answer, but here's the question. A patient is receiving NMES with an on-off ratio of 1:4. What is the duty cycle? Now, the duty cycle, it's all about calculating or knowing what the what duty cycle means. Duty cycle is calculated as the on time divided by on plus off time. So that's the total time. So the total cycle. So in our case of NMES that's at a 1:4 ratio, it means that it's on for 1, it's off for 4, but you remember the total cycle is the on plus the off time. So the total cycle is 1 divided by 1 plus 4. So this is where the correct answer is 20%. Duty cycle is defined as on time divided by on plus off time. On time divided by on plus off time. So that's what duty cycle is. That is different than the on to off ratio. That's what this is. On-off ratio is 1:4. So the on-off ratio would be 25%, but the duty cycle is 20%, on divided by on plus off. So that's another example of math. I have seen that question show up, and yeah, that was the royal pain on that one. All right, then kind of to finish up here on material before I start taking a bunch of questions. So the last thing I just wanted to mention are lab values, some critical lab values. Again, items you could just hurry and dump on your brain dump. Uh, the one I'd have you remember for diabetes would be your fasting blood glucose. You should have less than 100 for fasting blood glucose. This usually means you've been fasting for about 8 hours. Casual blood glucose, the safe levels, this is during exercise, they show up to your gym for exercise. They should be between 100 and 250. That's the safe exercise level. If you get above that, then you're in the caution zone, and then finally contraindicated. Activities contraindicated if it's above 300 milligrams per deciliter. So the ones to remember, normal blood glucose, fasting blood glucose less than 100, safe levels for exercise 100 to 250, and contraindicated above 300 milligrams per deciliter. Other blood counts you got to know are the lipid panel. This one's super painful until you just kind of line it up. We got about 50, about 100, about 150, and 200 for your HDLs. These are the happy density lipoproteins versus the low density lipoproteins. These are the bad ones. So you got high density and low density lipoproteins. You want more high densities. Those are good. Low densities are bad. Triglycerides should be less than 150. And finally, total cholesterol should be less than 200. So if you can just keep that in mind, high density, low density, triglycerides, those kind of go in alphabetical order, H, L, T, and then total cholesterol below 200. So 50, 100, 150, 200. Again, something you could write on your brain dump pretty quick and have that locked in. Other blood counts. I saw a really annoying question the other day about CD4 counts. So I included on this slide so you wouldn't be tricked by CD4. But white blood cells are typically between the 45 to 11,000 cells per millimeter cubed. That would be normal. If they're too high, that means you have an infection. If they're too low, then usually some type of immunosuppression is going on. The question I saw was about CD4s. Well, CD4s, these are directly related to HIV, the human immunodeficiency virus. So HIV directly attacks the T cells, the CD4s. So if the CD4s are in the pits, then that tells you that it's an HIV infection because CD4 is directly targeted by HIV. Hematocrit, 36 to 46%, different males to females, obviously. 12 to 18 grams per deciliter for hemoglobin, and then platelets should be 150 to 400. These are all the basic numbers you should remember. So if I were to just write something on my brain dump, I'd say 45, 15 for the hematocrit and hemoglobin. Those would be the targets I'd put there. Let's see. So question comes across. Let's see if I've got this right. All right. So Gian says, why are the exercise values for platelets so low compared to normal values? These are just the cutoff thresholds. This is why, like the ones I'd have you remember, if you remember one thing for test day is less than 8, don't ambulate. So if your hemoglobin is less than 8, the most likely cause for low hemoglobin is bleeding of some kind. You can have intraoperative bleeding. You could have post-traumatic bleeding. Anytime you have excess blood loss, blood volume loss, then the hemoglobin is going to be down. So if it's less than 8, no, then you don't ambulate. Less than 8, don't ambulate. With hematocrit, if it's less than 25, no exercise permitted. By the way, this is out of Goodman. This is Goodman's pathology book that I've got this table from. But anyway, less than 25 and less than 8 are your cutoffs for hematocrit and hemoglobin. Typically, if your white blood cell count is extremely low, no exercise would be permitted. You see less than 5,000 is not ideal. The normal reference range, 48 to 10, 8. You'll say to yourself, well, Will, didn't you say it's between 45 and 11? It is different in different resources, just so you know. That's my job with all my textbooks, is to try to find the range that fits most questions I see. So in any case, just remember, if the white blood cells are too low, no exercise would be permitted. Hemoglobin and hematocrit less than 25 and 8. Those are the key ones to remember. If I were to remember something from this table, less than 8, don't ambulate as a key value. Excellent. And then the last couple of numbers here we'll just talk about would be the Americans with Disabilities Act. It was passed in 1980s, 1989, 1990, right around that time frame. So it is in inches and not in metric measurements, but ADA requirements, 36 for the hall, 32 for the door. The goofy questions I saw once, I've seen several times, would be about carpet pile. It's how fuzzy the carpet is. Should be less than a half inch, so the carpet should be not very fuzzy at all. Threshold. Oh, the other math I see is the ramp slopes, the rise to run. So the slope is, it should be 1 to 12, meaning for every 1 up, you go 12 across. And if you look at imperial measurements, you see that, okay, for every 1 inch up, you have to go 12 inches over. So it means that for every 1 inch up, the ramp has to be 1 foot long. So in any case, it's a 1 to 12 ratio, which those of you looking at the math are going to say, well, Will, that sounds like an 8.3% grade, which is indeed the case. That's just 1 divided by 12. 1 divided by 12 is 8.3%. Maximum ramp length before having a break, before having to have a stop or a landing, is 30 feet. So that means that a ramp can only go up 30 inches before it has to take a break or turn or have a landing. Then it can go up some more, and then it has to have a landing. That's to be ADA compliant, you can only go 30 feet at a time. Ramp landings, 5 by 5, and counter height should be about 29 to 36 inches off the floor. So the one I'd remember here for sure is that 1 to 12 ratio. You got to know that one. 1 to 12 ratio is, got to lock in on that. Excellent. All right, I'm going to rapid fire through a couple of questions over in the Q&A feature, and then we're going to talk about test day. Or I guess before that, is wheelchair measurement important? It is. Yes, indeed. Wheelchair measurement is important. I'm trying to think how else to put that. There's a lot of measurements on the wheelchair that are important. The biggest thing about all those measurements is you want to make sure the patient fits in the chair. Little room on the sides of their hips so they're not compressed. Make sure that it's not too long so they don't have to like stretch to get their legs off the end. So those are some of the key ideas you have to have locked in. Leandre says, Sir Will is I like that, Sir Will. Is the bell curve calculation still part of the NPT? Yes, it is. I don't have that listed here. I can pull an image of that real quick, but the bell curve calculation, what is it? The 68, 95, 99.9 rule. So percentages, if I pull that up, you'll see that it looks something like this. It's really kind of an annoying but necessary deal. So if I pull up, here we go, like this image. Yeah, 68, 99. That's not it. Try this one. Sorry, let me just pull an image real quick. 68, 95, 99.7. Yeah. So if we were to show what this looks like, this is the calculation of a bell curve. And this is an example of what can show up on your statistics. 68, 95, and 99.7, referring to the standard deviations. So as you go each standard deviation over, you take in more and more of a standard bell curve. 68% is contained within one standard deviation, +1 and -1. An example of a calculation that could show up on test day would be something like this. What is the number of patients that are greater than -2 standard deviations? What percent, or not number of patients, I should say percentage of patients that are above -2.0 standard deviations? So to calculate that, do you want me to give you a second to calculate that before I do? So we want to know the percentage of patients above -2.0 standard deviations. So the way to calculate that is you say to yourself, all right, I know that there are that between +2 and -2 standard deviations is 95%. Half of 95% is what? Well, half of 95% is 47.5, right? So we know that 47.5% exists between -2.0 and 0. And because we want to measure everything above it, that will encapsulate 50% that is above 0. So therefore, the answer to the solution to this, everything above -2.0 is 47.5 plus 50 which gives us a grand total of 97.5. So that's an example of math that could be related to statistics on exam day. Excellent. All right, other questions that came up on the question comes across. Can you explain when the patella points inwardly during anteversion, retroversion, during medial lateral tibial rotation, any other condition? So the tibia will point medially if you have, I'm trying to think, it's usually like well, I guess it just depends by what you mean pointing medially. So if the inferior pole or the apex of the patella is pointed medially, chances are it's because you're pulling on the lateral side, the up and out side. So like genu valgum, a lot of times you get that disruption of the patella. It's a good question. I'm not sure I've got that answer on the tip of my tongue about the patella, what conditions would cause the patella to point inwardly. Yeah, tight medial structures. I would say that's kind of the go-to on the patella. Excellent. Let's see. Another question comes across. Mackenzie says, do you have any mnemonics for the different types of diseases and precautions or types of personal protective equipment? I'm having difficulty trying to strictly memorize them. So like as an example of personal protective equipment, I guess in my mind, if it's a respiratory illness like a influenza where you're coughing and sneezing, it's usually droplet precautions, which requires the face shield and the mask. If it's an airborne precaution like measles, herpes zoster, or tuberculosis, that requires the N95. So that's the real key there is it airborne or is it just droplet? And then the final one on that list would be contact. That's like MRSA and VRE, varicella resistant erythromycin. Yeah. No, enterococcus, sorry, VRE. So you have VRE and MRSA. Anyway, those are both contact precautions, which means you gown and glove anytime you're in contact with the individual. Let's see. What are the intervention types for each type of spondylosis? Usually, well, like spondylosis it's a flexion-based bias. So as best you can, you try to restore them to their normal posture, but usually you do flexion-based activities. Try to stretch open the facet joints. So a lot of flexion-based activities for most spondies. See, Katie says, if someone has tibial nerve palsy, what type of gait deviation would they have since they impact both dorsiflexors and plantar flexors? Well, the tibial nerve is mostly the posterior compartment. And so if you look at the tibial nerve, it's posterior compartment. So it's the flexors, remember flexors, it's not dorsiflexion. And the tibialis posterior is a plantar flexor as well. So if you have a tibial nerve loss, you will lose the push-off phase of gait. So your other foot will come down early. So we have a short contralateral step because of weakness related to the tibial nerve. So it affects primarily the plantar flexors, I should say that. I have a question about the nerve roots exiting the vertebral segments. This is related to the lumbar spine. So let me show you a picture of that. Let me show you that in the lumbar spine, things are a little bit goofy because the cauda equina separates out. And so with that cauda equina issue, then you get this wonky presentation where the disc hits the wrong nerve root. I'm trying to see. So I'm going to pull up a picture so you can see exactly what I'm talking about. But the idea here is that in the lumbar spine, where's my good picture about that? That's left to do. In the lumbar spine, and only in the lumbar spine, I want to make sure I say this probably 15 times. This principle only applies to the lumbar spine. And what I mean by that is that because you're in the cauda equina, things have separated out, then that means that things get a little bit wild down here. And so let me show you what I mean. In the lumbar spine, this is what happens. So don't pay any attention to the cervical spine for now. We're going to focus in on the lumbar spine. In the lumbar spine, The normal, and don't even worry about far lateral disc. That's very unlikely to show up on the test, so don't worry about that. A paracentral disc lesion is, so between L4 and L5, is likely to hit not the L4 nerve root. L4 does indeed exit below L4, but because it exits so far, it exits before it gets to the disc, L4 has made its escape, so L4 is doing pretty good, but L5 is the one that got hit as it travels down and past. So this is where this goofy thing happens, that an L4, L5 disc lesion is going to hit the L5 nerve root. And I want to make sure I say this probably 5 more times. This only applies in the lumbar spine and only applies to herniated discs. Herniated discs in the lumbar spine. Herniated discs in the lumbar spine. They're going to hit the wrong nerve root. And so that's why things are a little bit goofy. So therefore, an L4, L5 disc lesion is likely to hit the L5 nerve root, which leads to a loss of great toe extension. So that's an example of what could show up on the test. Devin says, are there normative values for red blood cells? Let's see. I had one question on Pete about it. I think above 150,000 was the normative value. Let's see. It's not listed here about the hematocrits. More than 5,000 per. Yeah, that is a good question. I don't know the answer to that directly. Yeah, someone will have to double check me on that. I'm on the normative red blood cell count. I don't have that. And it sounds like you encountered a question on that, so it is possible. Is sink height the same as counter height? Yes, that's right. All right. And let's see. So Courtney says, any good memorization techniques for wound dressings? If it's very absorptive, like a hydrofiber or a calcium alginate, then that would likely go on a venous ulcer, something with a lot of drainage. If it's a very dry wound, like an arterial wound, or even, like an arterial wound, something very dry, then you'll use something with very little absorptive capability, like a clear film, as an example. So as far as memorization techniques, I think I just memorize which one is most absorptive. So calcium alginate plus the hydrofibers, those are the ones to keep in mind. A question comes across, can you explain the difference between thoracic outlet syndrome occurring at pec minor versus the scalenes? Not sure I can. Most of the time, the thoracic outlet syndrome is caused by a compression between the clavicle and the first rib. Yeah, I guess I've never subcategorized it between pec minor versus scalenes. The pec minor is probably creating an abnormal scapular posture, which is pulling the clavicle into an incorrect position. And the scalenes are directly attached to the clavicle, so also creating, and the first rib, creating an irregular position. So I think it's just which muscle we're talking about. Question comes across, the roll and glide mnemonics for each joint. What I've seen, I don't know if this helps, but usually, like if you look at the upper extremity, the joints that we have to worry about, we've got the glenohumeral, we've got the humero-ulnar, the proximal radio-ulnar, the distal radio-ulnar, the radiocarpal, and then you get to, I think this is where you get to the MCP the MCPs, then the DIPs and the PIPs. And so if you go through this list, you'll say to yourself, all right, what pattern shows up here? Well, the glenohumeral joint is what? The glenohumeral joint is indeed convex. Moving on, concave. The humeral-ulnar is concave. The proximal radio-ulnar is convex. You see what's going on here, right? The distal radio-ulnar is concave. The radiocarpal is convex. The MCP is also convex. So I think I didn't talk about the intercarpal joints. I guess I'm not seeing too many questions on that. But the intercarpal joints, I want to say they follow the concave rule. Someone will have to double check me on that. And then the DIPs and PIPs, they all follow the concave rule. So it kind of goes every other concave, convex, or sorry, convex, concave, convex, concave, convex, concave, depending on how you group all that. So that's the upper extremity. The lower extremity follows very similar as well. That the hip is convex, the knee is concave, the ankle's convex. It goes convex, concave, convex, concave, all the way down there too. Excellent. Oh yeah, the carpal metacarpal. That's what I'm after. What is it? The carpometacarpal. That's what I'm after. So then it follows the same rule down. All right. Let's see. Other questions here. Just looking over the Q&A box. So we hit that one. Any mnemonics or devices to remember obstructive versus restrictive? I'm not sure I've got a mnemonic on that one. Obstructive is where the pathway is blocked. So like COPD is an example of obstructive. There's two subtypes of COPD, emphysema and chronic bronchitis. So that's obstructive. Restrictive is when you smash the lung shut. So like obesity, or you can't expand, like with a spinal cord injury, you can't expand it. Things are smashed shut. So that's how I remember or group obstructive versus restrictive. With pontine strokes, are the cranial nerves in the pons affected? Yes, that's exactly right. Daniel says any lumbar spinal injury will cause flaccidity and not spasticity, right? Remember, cauda equina injury. So the cauda equina in the lumbar spine will result in a lower motor neuron presentation. So flaccidity, not spasticity. Question comes across, will I publish this on YouTube? Yeah, so be sure to check out our YouTube channel, track that down. And there's a question, you asked a great question about forefoot and rear foot, valgus, varus, compensated, uncompensated. It's like a 1 hour lecture on that. So I probably won't. I've actually, if you go to my YouTube channel, I've got a explanation of forefoot, rear foot, valgus, varus that I think you'll really like. Excellent. All right, so let's talk about test day. So I know there's a bunch of questions. I probably won't be able to get to every single question, but I'll try to finish up here in a minute, and then we'll take a few more questions. So on test day, make sure that you arrive early, but not too early. What does that mean? Like, don't get there 3 hours ahead of time, but 30 minutes is a good solid start. Obviously, depending a lot on traffic. Arrive early, bring your 2 forms of ID. Plan your day, plan your clothing, dress to impress. Like, don't wear a tuxedo, but dress like a good PT. We are fabulous at looking fabulous, but also being very functional. Plan your snack. We already talked about that. Get a plan B for your travel to test day. This means getting a backup ride just in case your car breaks down that day or whatever. Just trying to prepare for contingencies. Anticipate check-in lines. It just takes some time. Like I had one student, she showed up to the test site and they were just turning the lights on. They're just getting going for the day. And they told her, hey, just have a seat, take it easy for a minute. Well, she did. And she waited like 5, 10, 15 minutes and still no one came and got her. 20, 25 minutes. A whole hour passed before she stood up and walked up to the desk and say, hey, just checking. Are you going to let me in here? And say, oh, we forgot about you. We thought you were a no-show. Anyway, it was a big disaster. So just anticipate that you're dealing with an office staff that's trying to get things going. So just double check with them, anticipate a little wait there. Smile for your check-in photo. They will not let you cheese it, so you can't be a smiley grin, but at least have like a power pose, a little smolder to your look. You're like, whatever it is, because you have to look at your picture a few times, especially on your score report. You get your score report. Try to at least look somewhat pleasant as you take your picture. Good posture is certainly associated with good interaction and mental acuity. So good posture. Try to average 1 hour per section. Talked about that. Mini mental breaks. This is critical, especially during the final sections of the exam. Try to take a couple of mini mental breaks where you rest for about 20 seconds, rest your eyes, take a couple of good deep breaths, and then re-engage with the questions. These will be more and more necessary the farther along the exam you get. Begin with a can-do attitude. Remember, there is a correct answer, and you, as I'm talking to you you're listening right now, you can find that answer. There is a correct answer, and you can find it. Try to find the most plausible answer, and then don't forget this, on test day, the test centers are notoriously chilly. They have the AC turned up so that the computers don't overheat. So make sure you have an extra layer or jacket on just in case the room is too cool for comfort. And then clear plastic water bottle is permitted. You just have to take the label off, and it has to have a lid. They have to check to see what it is. But you can bring water to your test seat. So bring a clear plastic bottle with you with no writing on it, no label. You can take that into your test seat, which that's a really cool feature. They added that a year and a half ago. And oh my goodness, just a chorus of hallelujahs on being able to bring water with you. Now, just be cautious not to overhydrate because there are clear problems there as well. Excellent. All right. So tell me, what questions do you have about the exam day experience? I know that it's stressful, and I guess as we come to a conclusion here, I just want to say thank you. Man, thank you for what you do. I know that whether or not you were part of our classes, just big thank you for your dedication to becoming excellent PTs. It's just what a great thing. Like, you guys are awesome. So Alicia says, do you know if we get our test results on the 5th or on the 12th of February? The answer is yes. The first week after, so February 5th, you will get a pass-fail result. And then before the 12th, you will get your test score. So test score will show up at about the 2-week mark post-exam. The pass-fail will appear on the 1 week after exam. Sarah says, is it emailed or mailed to us? I believe you get a notification in your inbox, and then you have to log into your FSBPT dashboard, and that's where you'll be able to visualize it. Question comes across, any tips for section 3? So section 3 is immediately post-break. Some people have a hard time re-engaging after the break. They've kind of lost their rhythm. So this is where that mini mental break comes in, where you open or close your eyes, take 2 or 3 deep breaths. You open your eyes and you try to engage 100% with the questions that are right in front of you. And you'll find that that's the best way to engage with the material. So just make sure that you're locked in tight on that. Question comes across, the link on Instagram for the free muscle action course doesn't show up as free. Is it no longer free? I believe it ended, our promo on the free muscle action course. Go back through Instagram and click through the link one more time. Just make sure that it didn't expire. I'm pretty sure we had it set to expire pretty quick. So do that as quick as you can. Be sure to check out Instagram. We're always giving away stuff. That's a great way to do that. Any helpful tips to remember the effect of altitude on cardiac pulm? The biggest thing to remember in altitude is that there's lower oxygen, so your body compensates by increasing red blood cell count. So we want to increase the red blood cell count. Let's see. Sir, can you explain the rotary component of the knee with regard to anterior posterior rotation briefly? Yeah. As the knee extends, it externally rotates. That's the screw home mechanism. So knee extension, lateral rotation. Marissa says, any interventions for incontinence? Yeah, interventions for incontinence, you'll do for urge incontinence, you do a fluid schedule plus pelvic floor exercises. And this is one we talked about in the VIP class a bunch. But for urge incontinence, a fluid schedule plus pelvic floor. For stress incontinence, you do pelvic floor muscle strengthening, PFM. Daniel says, can we bring water bottle and food to the exam room? You cannot. You can only bring the water bottle into the exam room. The food has to stay out in your locker. Again, they provide the locker for you. Everything's totally prepared for you. Just bring it. You dump it off in the locker. Don't forget to put your cell phone in there. You don't want to. I had one girl, she forgot about it in her pocket, and she pulled it out during the exam to use the timer feature. And anyway, they caught her and they're like, hey, there's test material on that phone. She's like, I was just using the timer. Anyway, she was suspended from the exam for 2 years. So don't do that. Bad idea. So only water can be brought with you to your test seat. What are your tips on mental endurance in the last section of the exam besides the mini mental breaks? Besides the mini mental breaks, it's really easy to fatigue 5 hours in. And so you've practiced. That's probably the preparation. That's where that really kicks in. It's like a marathon, that the preparation really kicks in during the last miles. And so your preparation and being awake and focused is something you have to prepare your mind to be able to do. And then during exam day, you'll do the mini mental breaks. Any snack recommendations? I recommend like trail mix is a really good fit. Trail mix, it has lots of proteins and fats in it. Tends to last a little bit longer than just straight sugar. Bibbin says, does the result vary by state like New York or Texas? It does not. It is uniform across every jurisdiction in the United States. There's no difference in score or cutoff range. It's all managed from a national level. Are you able to move your hands and feet in your seat? The answer is yes. As long as you don't hit your neighbor, like obviously be discreet about it, but you know, you can move your hand and wrist, you know, just go like that. Just, yeah, be very cautious that you're not hitting your neighbor. And with that in mind, you'll be able to easily, that'll be your secret weapon on test days, being able to move your hands, wrists, feet. You cannot stand up and walk though. You just have to be in your seat. You can't really move right, for example, crossing your legs. Yeah, that's not true. You're in your little cubicle. You can sit there. You can lean back, forward. You move your hands, wrists. Just as long as the proctor doesn't think you're like signaling to your neighbor. Yeah, just be very discreet. Is it correct to think that dorsiflexion follows knee flexion? Yes, it does. And that's part joint mechanics as well as center of mass. So, but the short answer is yes. Dorsiflexion, knee flexion, plantar flexion, knee extension. All right. And then how do the practice exams in my bundle, so the PT final exam bundle, how do they compare to the PETs? I've taken 4 of those exams and scored in the high 70s. So usually our exams are a tiny bit more difficult than the actual exam. So by a slight margin, we tend to be a little bit harder than the NPTE, the PETs. So therefore, if you score in the 70s or higher on our exams, that puts you in a really strong position. Really, really strong. All right. Arthur says, what's the process for an unscheduled break? It's the same as for a scheduled break. It's just that, I won't take the time to show it. But basically, at the end of each section, a screen jumps up and says, would you like to take a break? Yes or no? And for the unscheduled breaks, it'll say, would you like to take an unscheduled break? You can click yes. If you do click yes, then the screen blanks and it says, your unscheduled break has begun. And it shows your overall clock timer because there's no mini timer there. If you are just taking your regular scheduled break, the same thing, it pops up, says yes or no, do you want to take your break? And then you'll see a 15-minute mini timer. Bibbin says, what's the correct number to pass out of the 180? It's right in the 127 range, 125 to 130. It is a little bit different on each exam administration because some exams are slightly harder, some are easier. Carla says, I already bought 2 PETs. What other tests do you suggest for my next try in April? Well, obviously the PT final exam tests are great. You get 6 of those. I mean, there's 6 of them. So there's another pair of PETs. There's 2 pairs you can buy. So 4 PETs available for purchase. So I'd probably buy the other PETs as well. So there's, 2 PETs there. Or sorry, 2 pairs of PETs, I should say. 2 pairs of PETs. All right, guys. Well, with that, let's go ahead and bring this to a conclusion. Hey, I really appreciate you guys. Appreciate the questions. Appreciate the content that we've talked about today. And most of all, I just appreciate you. Appreciate the efforts you put into this to becoming an excellent PT. I hope this was helpful. I hope some of the little mnemonics and acronyms were helpful. I would recommend as you head into test day that we kind of wind down from heavy duty studying and spend more of your time just reviewing. So we're talking like your flashcards, your notes, all those things would be extremely helpful. Be very relaxed in your studies. This is just very much a willism that I can't not study the day before the test. So I just try to do it in a very relaxed way. So very, very relaxed, easy chair, natural light, going through a few flashcards, 3 or 4 practice questions, then take a break and then do that again. So anyway, that'd be fun. A huge thank you to those of you who are our crash course participants as well as our VIP participants. It's been fun. This quarter, it's just been so fun going through the content, the practice questions. Let me tell you, like this is what I get up every day, having a ton of fun doing. I still practice as a physical therapist, so I still have an active license. In fact, I just had a couple of patients this week. I do home care. It's very flexible, so I can do. My wife told me I couldn't have 2 full-time jobs, and so anyway, that's what I do. I'm still practicing PT. I still do the documentation and the billing. I know what you're up against. So anyway, I know you guys can do this. It's so worth it. And a really big thank you to you. Question says, are you from Idaho? I am broadcasting to you from my blue cubicle in Idaho. So you guys totally got this. Big Will Crane fist pump. You got this little positive affirmation. I'll catch y'all later. Let me know how it goes on the exam. Sure appreciate you guys. I'll talk to you soon. Thanks, guys.